Okay, thank you very much to all participants. So this is our again joint session, ISMIN and ACNS. It is our privilege to have everyone here. So today we have a three presenter. At the same time, the chairman will be Asra Al-Fawzi. I'm very happy to see every one of you. And maybe I would like to invite Professor Kosaku to give some welcome message for this session.
Okay, thank you so much. So today we have the great neurosurgeon lectures. And we're very much looking forward. And also the Mao Yokota. But today is a Women's Day.
Oh, yes. Today is Women's Day? Oh,
yes,
very nice to meet you.
Congratulations, Mao Sensei.
Yes.
So let's start.
Thank you.
Okay, I think the chairman today is Asra Al-Fawzi. So I think we would like to invite Professor Asra Al-Fawzi to chair the session to introduce the speaker, and we can start from now.
Okay.
Asra.
Thank you, Rasmi, and thank you, Professor Kosaku. Thank you, all the senior here. And this time we have a very important webinar, I think, especially for young neurosurgeon. The theme of the webinar this time is minimally invasive techniques, and we have three distinguished speakers here. First is Professor Alberto Feletti from Verona, Italy, and then Professor Kosaku Amano from Tokyo, Japan, and also Professor Xin Yang from Tianjin, China. And the first speaker will be Professor Alberto Feletti. He will talk about the neuroendoscopy as a game changer in neurosurgical emergency. Please, Professor Alberto, the time is yours.
Thank you, Asra, and thank you, Professor Kato, and all the organizers for this opportunity to join the Congress. Let me see if I can share my screen. Okay, is it visible?
Yes.
Yes.
Okay. So thank you very much. Yeah, actually today is the International Women's Day. So greetings to all the women, of course, especially neurosurgeons. I will talk about neuroendoscopy as a game changer in acute neurological emergencies. I have just this disclosure, but it's not relevant to the topic of my presentation. I want to start with this slide showing the instruments that we can use during this kind of surgeries. Of course, we have rigid scopes and we have also flexible scopes, and we will see that in these cases we must master both instruments. Which kind of emergencies can we face in our daily clinics? So I group them according to some similarities. Of course, there is a group of obstructive hydrocephalus situations, another group intracranial hypertension like arachnoid cysts can determine, hematomas, very interesting group, and infections. So let's start with obstructive hydrocephalus. I want to point out since the beginning that I will show many emergency situations. In some of them, I would say neuroendoscopy is useful. But when we talk about neuroendoscopy as a game changer, you will see that, in my opinion, the group of pathologies is a bit more restricted, but I will show you later. So this is an example of a pathology which can be urgent. The enlargement of one or both lateral ventricles because of foramen of Monro atresia. Of course, in this case, neuroendoscopy can be useful to fenestrate one of the Monros. Another situation is when we have a patient already with a VP shunt, like in this case. Neuroendoscopy can be useful in these cases where there is a obstruction of the contralateral lateral ventricle So as you can see, in these cases, we can perform a septostomy. So very easy, straightforward, and we can fix the problem of the patient very easily. So in this case, I would say it's not a game changer, but it's useful. What about EVD, ATV? ATV, of course, is most often elective surgery. However, there are some cases when ETV might become urgent, like previously shunted children who present with a malfunction of the VP shunt. In these cases, the literature is quite clear nowadays, saying that ETV can be successful in these patients presenting urgently to the hospital, and it can be successful, stably successful, in around 60–65% of cases. Another situation when neuroendoscopy can be very useful, probably not game changer, but very useful for sure, in these cases with a huge tumor in the posterior third ventricle, giving obstructive hydrocephalus. Of course, we can fix immediately hydrocephalus problem with an ETV, and we can also perform a biopsy for a diagnostic purpose. In this case, you can see the immediate postoperative MRI showing the resolution of the acute hydrocephalus. It was a germinoma, and the child was treated with radiation therapy, and the tumor shrinked significantly. This slide is here just to remind you that the place where we perform ETV is not without any function. As I remember, I was taught when I was a student in medical school, there is an organ, a circumventricular organ called the median eminence, which has some functions. This is interesting to know, just to try to tailor the ETV in order to reduce the damage to this circumventricular organ. Another very interesting situation that can be urgent is hydrocephalus due to colloid cyst. So as we know, microneurosurgery has been the gold standard for many years. However, it has postoperative morbidity that can be quite high, mortality not negligible, and of course, vascular complications and fornix damage, especially in transcallosal microsurgery, might happen. Many years ago, endoscopy raised as a different way to perform this kind of surgery. This is just one of the many studies published in the literature. It's an Italian cooperative study, which showed that in all cases, of course, it was possible to fenestrate the cyst. But as you can see, the cyst removal is very rare to be obtained. And in most cases, the capsule was just coagulated. If we check the literature, there are 3 meta-analyses about the comparison between neuroendoscopy and microneurosurgery for colloid cysts, and all these studies agree saying that gross total resection is higher with microsurgery, recurrence rate is higher with endoscopy treatment. However, shunt dependency and complications in general favor endoscopic treatment. This is true for the past literature and the past ways we used to perform endoscopic removal of colloid cysts, but there has been an evolution for this kind of surgery. Initially, I remember many years ago, we used to just fenestrate the cyst and aspirate the colloid. But if you just do this, of course, you may expect the reclosure of the fenestration and the recurrence of the cyst. Then at the later stage, we learned that just one fenestration is not enough. It's better to perform at least 2 fenestrations. In this way, CSF moving inside the cyst will decrease the risks of the cyst to recur. But nowadays, it's possible to do much more than this. we are able not only to fenestrate and aspirate the cyst, but also to remove the wall of the cyst. And at least in my experience, and also in a few other colleagues' experience around the world, in this way we are able to maintain the low complication rates of neuroendoscopy and reach the effectiveness of microneurosurgery. I just want to show you one case. This is a patient who was admitted in an emergent situation, and with just endoscopy using a rigid and a flexible endoscope, we could not only fenestrate, but also remove the wall of the cyst with what I like to call the spaghetti technique. You twist basically the forceps to remove the wall of the cyst, and this is possible in the vast majority of cases. Of course, with the flexible scope, you can also inspect the third ventricle, making sure that there are no remnants, there are no pieces of colloid cyst or the cyst itself. Aqueductoplasty, this is also a situation that usually it's elective surgery, but sometimes you may have situations which you have to manage in an emergent case. Like this lady was admitted in a bad neurological status, acute bad neurological status. And in this case, I was able to see a very transparent and tiny membrane obstructing the cerebral aqueduct. So I fenestrated the membrane. I discourage doing aqueductoplasty in real stenosis, but if there is just a membrane, it's possible to fenestrate quite safely. So another group of situations that might show up in an emergent situation are those patients with arachnoid cysts which decompensate. In these cases, endoscopy, again, maybe it's not a game changer, but it is very useful to fenestrate the cyst into the ventricles, like I have done in this case, as you can see, with a rigid scope in this case. This is another case of a huge arachnoid cyst in the posterior fossa. Again, I used in this case a flexible scope to fenestrate it. I want just to show you the final stages of the surgery because it was possible to see a very nice anatomy of the posterior fossa with the tentorium, the free edge of the tentorium, the straight sinus, and the Galen complex here. Another very important group, I was fast until now because I think this is the most important group if we talk about neuroendoscopy as a game changer. For example, intracerebral hematomas, we know that the standards of treatment has always been medical treatment and surgery reserved only to those cases where the hematoma was life-threatening. There have been many studies, many trials showing that surgery is not able to improve the functional outcome of this kind of patients. However, recently, as you know, the Enrich study showed that minimally invasive techniques can actually improve the functional outcome of our patients. And we know that we are able to perform this kind of surgery even through a simple bar hole with an endoscope, sometimes using devices like the Nico or the Artemis by Penumbra to remove and fragment particularly stiff clots. Look at this CT scan, preoperative CT scan, huge intracerebral hematoma, which I operated with an endoscope through simple bar hole. As you can see here, I'm using the Artemis device to fragment very hard clots and aspirate them. And this is the immediate postoperative CT scan with a very nice removal and a really minimally invasive approach. In this case, we can say that neuroendoscopy is really a game changer because it's able to improve the functional outcome of our patients compared to other kind of treatments. This is the instrumentation, of course, neuronavigation, and sometimes I use this device if the clot is particularly stiff. Another group of patients for which neuroendoscopy is a game changer is patients with intraventricular hematoma, which carries a very high mortality, up to 80% in some series. It's an independent prognostic factor for poor outcome. And there are many reasons why this is a very bad situation, not only because it leads to hydrocephalus and intracranial hypertension, but also because there is a chemical damage with an inflammatory response of the brain system, of the brain and the brain stem, and a direct mass effect with a reduced cerebral flow, especially in the posterior fossa. Of course, usually we treat these patients with EVD, which is a very simple procedure. It allows for fast resolution of acute hydrocephalus, but there are many cons, like it gets frequently obstructed. We have to wash these EVDs. We have to replace them. We have to place them bilaterally, and all this leads to a longer hospital stay and an increase of complications like infections, for example. Of course, we can add fibrinolytic therapy, but it has been shown by the literature that it doesn't substantially improve functional outcome for the patients. So the only way we have nowadays to remove completely and in a fast way, the blood clots from the ventricles is using endoscopes. And if you can see here, this is the immediate postoperative CT scan after endoscopic treatment. As you can see, we are able to remove the blood clots not only from the lateral and third ventricle, but also from the fourth ventricle, which is very important. Of course, we can also use rigid scopes to do this kind of surgery, but only with a flexible scope, you are able to remove the blood clots also from the fourth ventricle. And removing the blood clots also from the fourth ventricle is very important, because it has been shown that the fourth ventricle dilation, hemorrhagic dilation, is the most significant outcome predictor for this patient. So we need to remove the blood clots even from the fourth ventricle if possible. This is possible, of course, only with a flexible endoscope. We have published some papers in the past years showing a benefit in terms of mortality and VP shunt rate, and also improved outcome when we treat patients with an endoscope. Also, this study published by our group a few years ago compared a group of patients B treated with EVD alone and a group A treated by endoscopy. The black bars are the patients that require the VP shunt after the acute phase. As you can see with the endoscope and with endoscopic treatment, this rate decreases significantly. Also, in this case, we have some reviews and meta-analysis comparing this endoscopic treatment with other treatments, and all of them agree saying that there is a lower shunt dependency if you treat this patient with an endoscope, lower infection rate, their decreased length of stay at hospital, reduced mortality at 6 months, and improved functional outcome. How to do this kind of surgery? You see the techniques, the instruments are very, very basic, like a peel away and a syringe for aspiration and a pipeline for irrigation. The access is very important, must be not too lateral, otherwise you will struggle entering the cerebral aqueduct. Irrigation maneuvers and aspiration maneuvers are the basic maneuvers in this kind of surgery. Irrigation to unveil anatomical landmarks, and aspiration, of course, to aspirate blood clots. This video shows the phases of this kind of surgery. Initially, the situation is this, very frustrating. You can see only dark red blood clots in front of you. You might become very discouraged initially, especially during the first surgeries, but you don't have to be discouraged. You know that lateral ventricles are very big, so it takes a bit longer time to aspirate the blood clots. but you have to keep aspirating. Of course, you have to stop aspiration when you see this, when you see white, because white means ependema. So when you see white, you have to irrigate to clarify the vision in front of you. But very soon you will be able to see some landmarks like the choroid plexus, and you can follow the choroid plexus all the way to the back of the ventricles to remove the blood clots from the posterior part of the lateral ventricle, and also follow the choroid plexus forwards until you see the fornix and the Monro foramen. At this stage, you have to enter the Monro foramen and aspirate the blood clots from the Monro foramen, like here, I'm doing here. And finally, you can see some landmarks in the third ventricle, mammillary bodies, the tuber cinereum, and the infundibulum. And after that, you have to orientate the tip of the scope to the posterior part of the third ventricle. Same here as before, just aspirations until you see the ependema. When you see white, do irrigations, and the landmarks will appear, like the aditum of the cerebral aqueduct. I want to point out that for the third and the fourth ventricle, you need really a few minutes to complete the aspiration of the blood clots, because they are small ventricles. Here you can have a nice view of the posterior part of the ventricle with the posterior commissure, abenular commissure, the pineal recess. And then, of course, you have to enter the aqueduct, which is also obstructed by blood clots, and do the same aspiration and irrigation maneuvers. I will go fast just for the sake of time. And at the end, after the aspiration, you can see fourth ventricle with the Luschka foramina and the Magendie foramen. You can approach the Magendie foramen, and you can see the picas, and aspirate the blood clots even from the cisterna magna. And this is the final vision when you withdraw the endoscope. Very nice view of a free fourth ventricle. And I always like to show the very last moments of the withdrawing, because you can appreciate no significant damages occur to the cerebral aqueduct after you have performed this kind of surgery. You can couple this technique also with, for example, coiling. In this case, the intraventricular hemorrhage was due to a ruptured aneurysm, which was coiled, and then the patient underwent endoscopy immediately. This is even more evident, basilar artery aneurysm, which was coiled, and this is the immediate postoperative CT scan after neuroendoscopy. As you can see, you can really decompress the posterior fossa immediately. So similarly, you can do with clipping. I clipped this MCA aneurysm, blood clots were still there, and I did neuroendoscopy immediately to this patient. This is the immediate postoperative CT scan after neuroendoscopy. Timing is very important. You have to perform this kind of surgery within 24, maximum 48 hours. And I always leave an EVD for 2 or 3 days closed, and then I remove it. And the very last group includes patients with infections. Also in this case, you can see this patient with a abscess, double thalamic abscess. This is the preoperative CT scan, and I made an aspiration of all the pus inside the ventricles and even inside the thalamus. As you can see, the abscess was open into the ventricle, so I entered the thalamus, with the abscess within the thalamus, and I aspirated all the pus inside these abscesses. And this is the postoperative CT scan, and the patient actually survived with a very nice functional outcome. Similarly, you can use endoscopes to treat spinal edema. No need to open all the spinal cord. You just need a small opening, and then with a flexible endoscope, you can navigate inside the canal and do the same maneuvers of aspiration of pus or blood clots, like in this case. So I want to conclude saying that we must be able to use both rigid and flexible scopes in this kind of situations. There are some situations where endoscopy is very useful, like acute hydrocephalus, arachnoid cysts, but neuroendoscopy, in my opinion, is a really game changer in these situations: colloid cysts, intraventricular hemorrhage, ventriculitis, and intracerebral hemorrhage, because we can change the outcome of our patients using endoscope. Especially for IVH, which is treated in the same inefficient way since decades, there is an urgent need to make an advancement, and flexible endoscopy is this advancement. Of course, it's safe, but it requires a proper training. And for this reason, I think we need to train young neurosurgeons. They must be more exposed to neuroendoscopy. I want to conclude with two invitations. In late September, early October, we will have the EANS Congress in Hamburg. So you are please all invited. There is a joint meeting with the Japanese Society of Neurosurgery, and also you are invited to join the International Conference on Complications in Neurosurgery, which will be in June in Italy, in Rimini, for the first time. It will be outside India. Thank you very much from Verona.
Okay. Thank you, Dr. Alberto, for your beautiful presentation. I think you showing us, kind of endoscopic procedure for all kind of variation of the disease in intracranial pathology. So it's very good presentation. And maybe any comment from audience or from Dr. Asmi or from Professor Mao Yokota. Please, Dr. Asmi, you have any comment?
Okay, thank you very much, Alberto. Very excellent presentation. You demonstrate very well how flexible endoscope can do, I think, for certain case much better than rigid endoscope. Especially, I'm interested about the intraventricular hemorrhage in stroke, as well as the ventriculitis. So one of the technique that you mentioned, that you use the scope to retrieve the hematoma, and you can get direct down to the fourth ventricle, which is excellent advantage compared to the rigid endoscope. So my technical question is, number one, the flexible endoscope, usually the working diameter are rather small. In post-stroke hematoma, usually the clot are organized, so they are a little bit thick. How do you retrieve the clot? Is it you use a special suction or sucker, or you use something to break the clot first? So that is my first question. And second question is, when you get into the fourth ventricle through the aqueduct or sylvius, and most of the concern is the damage to the nucleus, third and fourth nucleus at the aqueduct area. So what is the size of the flexible endoscope, and how do you maneuver your tip of the endoscope as you withdraw? Because if you don't straighten it well, so you may damage the area as you withdraw your endoscope. So Alberto.
Thank you, Asmi, for brilliant questions, I have to say. You made the point. Of course, I didn't have enough time to explain everything during my presentation, but okay, so about the possibility to find some very stiff blood clots. Of course, I agree with you. It's the experience we all have, both for ventricular hemorrhage and also for intraparenchymal hemorrhage. So for intraparenchymal hemorrhage, nowadays I use only a bar hole and a rigid endoscope, and in most of the cases, aspiration using an aspirator through the working channel of the rigid scope is enough. When the clot is very stiff, I use that device, the Artemis device, which is a sucker with a fragmenter at the tip, so it can, fragment the clots. For the ventricular hemorrhage, of course, I pointed out that it is very important to manage these patients early. I mean, preferably before 24 hours, maximum 48 hours, because if you treat them immediately, the clots in the ventricles are different compared to the clots in the brain, probably because CSF has some, effect on the clots. They get stiff maybe a bit later, so you can easily aspirate them. I didn't have to use any other instrument to aspirate them. But I have memory of a couple of cases I operated later than 48 hours. It was simply impossible to aspirate them. And with the flexible endoscope, you don't have like those devices, the Artemis devices, and so on. So it's very important to do surgery for the ventricular hemorrhage within 24 hours, maximum 48 hours. The diameter of the flexible scopes can be very variable. The ones I use are the pediatric one, which is 2.8 millimeters outer diameter, or the adult by Storz, 3.9 millimeters outer diameter. There is a very nice flexible endoscope by Olympus in Japan, very beautiful, but the diameter is 5 millimeters. 5 millimeters is way too big to enter the cerebral aqueduct. So in my experience, if you want to navigate the cerebral aqueduct, the endoscope must be with a diameter lower than 4 millimeters. If it is bigger than 4 millimeters, you will create damages. Of course, to reduce the likelihood of getting damages to the aqueduct, there are some techniques you mentioned. You have to get a proper training, first of all. It's not the first endoscopic surgery you want to do as a young neurosurgeon. But for example, you have to place the bar hole quite medially, so the direction of the scope is almost parallel to the direction of the cerebral aqueduct. Another very important point is when you withdraw the scope from the fourth ventricle, you have to release the lever, which moves the tip. If you release the lever, you don't risk your endoscope to be hooked, and maybe if you withdraw it, you will get damage. If you withdraw without touching the lever, the flexible scope is flexible and it will adapt to the shape of the cerebral aqueduct. Doing that, I had never experienced significant problems in this kind of surgeries.
Excellent. So my second technical question is about the ventriculitis, because you show a thalamic abscess. So in our experience, we use a rigid endoscope, but when we use rigid endoscope, we have to do bifrontal, because we could not get access through the lateral ventricle on the opposite side. There will be a pocket of slough collecting. So for this approach, do you use a single monoventricular? So is it you approach from one side or you go from the contralateral side? Because the best to approach the thalamus is from the opposite side. So you can get very nice, perpendicular to the target. So how do you perform for these very beautiful cases?
So for the cases I showed, I used only one bar hole. Of course, I study the anatomy and the trajectory case by case, whether to place the bar hole ipsilateral or contralateral. Sometimes contralateral is easier, I agree. But if you can manage to use both rigid and flexible endoscopes, you really need just one bar hole. Even if you want to start that kind of surgery with a rigid endoscope, maybe you want to be faster, you want to have a clearer vision initially, and then you want to go to the contralateral ventricle, you can change the endoscope and use a flexible scope, do a septostomy, and go to the contralateral ventricle. So I think it's very important not to be rigid neurosurgeons, in the sense that we must use both rigid and flexible endoscopes. I know that many, not probably in Asian countries, but in Europe, in the States, many surgeons are scared about the flexible scopes, which is nonsense, because they are very flexible and they adapt to the geometry of the ventricles very nicely. So I think one bar hole is definitely enough for these cases.
Okay, thank you.
Thank you.
Okay, thank you, Dr. Asmi. And also thank you, Alberto, for your kind explanation. And maybe Yokota Sensei,
Hi.
any comment or question, please?
Okay.
Yeah.
Thank you for your wonderful presentation, Professor Albert. So in our hospital, as you said, same technique we use, and we perform the surgery for IVH. We remove the tumor with the Olympus flexible camera scope until third ventricle hematoma. But over the fourth ventricle hematoma, we use Stolz flexible scope. We use like you, yeah.
Yeah,
But
yeah.
very scared. I felt always scared.
To enter the fourth ventricle, you mean?
Yes, fourth
But
ventricle.
I think the technique you described is very, very nice. I mean, using a rigid scope initially you can also be faster maybe with a rigid scope. But entering the fourth ventricle, again, I think it's important to point out, especially for young neurosurgeons, you need to get a proper training using a flexible endoscope to do other kind of surgeries first. And when you are able to, maneuver the flexible scope to do all the other surgeries, then try to enter the fourth ventricle, of course, if there is indication to do so. But it's important to have the proper instrument. The Olympus, as I said, it's 5 millimeter diameter, I think. The Storz is less, it's thinner. So if you use a scope with a diameter less than 4 millimeters, and you do very careful maneuvers and you release the lever when you withdraw the scope, I think you don't have to be scared at all. Absolutely. At least in my experience.
Okay. And so I have one more question. What size cyst do you use when you remove the arachnoid cyst or choroid cyst? How millimeter cyst? Cyst size?
Oh, the cyst size?
Cyst size.
Oh, any kind. Okay, so for arachnoid cysts, I only fenestrate. I don't remove the cyst. Okay.
So for choroid cyst, how about?
For colloid cyst, I remove any size, really. So for colloid cyst, I use both rigid and flexible scopes. Initially rigid sometimes because I want to go faster with the aspiration of the colloid. So initially I do a fenestration on the wall of the cyst. I do the aspiration of the content. Sometimes if the content, sometimes the colloid is very soft and easy to aspirate, but sometimes it's very hard. So in those cases, again, I use the Artemis device. In really 2 or 3 minutes, I'm able to remove all the content. And then I, take the wall, and with the twisting maneuver, the spaghetti technique, I carefully remove the cyst. I think in those cases, though, it is, of course, you have to be very sure about the maneuver you do, because you may provoke a bleeding. You don't know where the cyst is attached on the roof of the third ventricle. And this is exactly why I like to insert the flexible scope, because with the flexible scope, I can enter the Monro foramen and inspect the roof of the third ventricle and see if the cyst is attached to the internal cerebral vein or not. So I really want to point out that these maneuvers must be done with a visual control, and the flexible scope can give you this visual control. And in the case of colloid cysts, I do remove the wall, absolutely, yes. Nowadays, it's possible to remove completely or almost completely.
Okay, thank you.
Arigato gozaimasu.
Thank you, Yokota Sensei. And Dr. Ben, maybe you have any question?
Yes, and hello, Alberto. Nice
Hey,
to
Ben.
Hello, how are you
Long
doing?
time,
Nice.
long time no meet.
Yeah. We'll meet very soon, I guess. And
Hopefully.
it's a very quick lectures. And I think using the endoscope for cord evacuation is highly depends on the endoscope and also the introducer that are available in your unit. And I can see that you have the good stores flexible endoscope, which is good. And I attend the flexible endoscopy course, and I really feel that this endoscope is really, really useful if it's available. And for the widget endoscope, I would like to ask about your experience. So for easily caught for early caught, so maybe the as you mentioned before, the bisection itself is usually okay, but I do encounter some difficult caught and which require bimanual surgery, like in open surgery. In that case, I would use like what we call the cerebral corridor creator, just like a plastic tube to introduce two instruments so that you can have your bipolar and suction together for the bimanual maneuver. So what do you think about those the size of the introducer that you would use in your experience? Will it be depends on case by case, or can you predict the difficulty of the surgery and then to choose the correct size of the introducer?
Yeah, thank you, Ben, for the very interesting question. Actually, I also used in a few cases those transparent introducers. You need something more than a simple bar hole, a mini craniotomy. I think it's a very useful corridor, absolutely, especially in those cases you were mentioning. In the last cases, I have never used those introducers because I got more familiar with using just a bar hole and a rigid endoscope. And since I am using the Artemis device in cases the clots are very stiff, I was always able to remove them. Of course, again, you need to perform this surgery within the first 48 hours. Otherwise, the clots will be too stiff, even for the Artemis device. So to answer your question, in my experience, I always try to remove these intraparenchymal blood clots within the first 48 hours with just a bar hole. And the introducer is a peel away. It's maybe 5 millimeter diameter peel away, very, very small. In most of these cases, this is enough to obtain a very nice decompression and removal of blood clots. You know, even if you leave a small remnant of blood, sometimes the blood clots are not all the hematoma, just one part.
Yes.
If it is just a small part, you can leave it there, no harm to the patient. Yes. You need to remove majority of blood clots. But if you encounter cases when you are not able to remove satisfactorily the blood clots through a small bar hole and a peel away with a rigid endoscope, in those cases, I would open a small craniotomy and use the transparent introducer you are mentioning. Absolutely. I think it's a nice tool, but I would reserve it as a second option in case I'm not able to remove properly the clots with an endoscope.
I see. Thank you so much. And great lectures as always. Thank you.
Thank you.
Okay, thank you, Ben. And Dilshot, you have any question? Please.
Yes. Thank you so much. Good day to everybody. Nice to see you again, dear friends. Alberto, do you have any tips how to enlarge the foramen of Monroe in case if you need to enlarge it endoscopically? Because you don't have to damage the fornix, you don't have to damage the other structures in the way to the third ventricle.
Yes, thank you, Dilshot. Good to see you. The tips are quite simple. in the cases I have done this kind of surgery, I carefully inspect the obstructed moroforamen, and I want to be sure I can visualize a transparent membrane. So, you know, sometimes, very often, when you have an atresia of the moroforamen, there is a membrane. In some parts, this membrane is thick and opaque, and you cannot see through. But in some parts, it's kind of transparent. The same principle applies to the obstruction of the cerebral aqueduct. If there is a membrane, you need to be sure that it is transparent before puncturing that membrane. Of course, I always try to fenestrate the membrane in the point where it is transparent, because I can see what is behind the membrane. And I try to do the fenestration at a safe distance to the fornix and also to the venous angle, because we don't want to damage also the internal cerebral vein, of course. So the tip I suggest is to carefully inspect, before doing anything, carefully inspect the obstruction and select the transparent area, the most transparent area you can find.
Thank you so much. And another question is, after draining the abscess, in case of thalamic abscess or any other abscess, do you use intraventricular, intrathecal antibiotics as routinely or in selective cases?
Yeah, not routinely. We always discuss this kind of situations with our infectivologists. In selected cases, they advised to use intrathecal antibiotics, but it's not routinely used. It depends on many different features, like the antibiogram and neurological conditions of the patients and so on. But sometimes we used.
Thank you so much.
Okay.
Thank you.
Thank you, Alberto, for your great explanation. And I think because of time, we have to move to second presenter. And I will introduce Professor Kosaku Amano from Tokyo Women Medical University Hospital, Tokyo, Japan. And he will talk about the surgical strategy for pituitary tumors invading the cavernous sinus. Please, Amano Sensei, the time is yours.
Hey.
Yeah.
Can you see it?
No, we don't see
Okay,
your
just a
presentation yet. Yeah.
Just a moment. How about this?
Yes, please make a greater view.
Okay. So my topic is the surgical strategy for pituitary tumors invading the cavernous sinus. The reason why we should remove the pituitary tumors invading the cavernous sinus, these three, cranial nerve palsy, hormonal remission in functioning adenoma, and gross total resection in case of codomer and craniopharyngioma.
先生、スライドショーにしてもらっていいですか？
はい。
ス
スライドショーになってない。
スライドショーに
Yes.
なってない。
うん。
おかしいな。待ってください。
Yes, a greater view. You can change the view.
とりあえずこれでちょっと大きくなりました。なっ
少し大き
てない。
くなりました。
Yeah,
じゃあ、
okay.
やめ、
Yeah,
こ
okay,
れで、
please.
じゃあこれでいきましょう。
Cranial nerve palsy, we reported this paper. Pituitary apoplexy, tumor invasion, inflammation. These are the reasons why cranial nerve palsy occurred. And this case is pituitary adenoma apoplexy case, and including the inflammation change. Apoplexy case, more than 80% improved without surgery. But I believe operation shortened the symptom duration, so it's meaning. And also the malignant tumor like this, such as malignant lymphoma, metastatic tumor, and this case is a plasmacytoma. It often present a cranial nerve palsy. So this case also, after 1 week's distance palsy improved, and 1 month mostly improved. So we need operation for the cranial nerve palsy. And hormonal remission. This case is this is a cross grade, and especially cross 3B and A is important. And recently, grade 4, we can remove totally. And grossal resection, functioning pituitary adenoma, chordoma, pharyngioma, we need to remove the tumor inside of the cavernous sinus. And at the time, we need innovation in instrument, Novoflex forceps, malleable suction attachment, bending ring thread. All of these are useful to remove the tumor in the cavernous sinus. And also the ICG endoscope is very convenient to remove the tumor in the cavernous sinus. We can judge the cavernous sinus is still survive or not. And recently, 4K with ICG endoscope we introduced. It is very outstanding endoscope. And I show you the case of functioning adenoma. In case no functioning adenoma, we remove only within 99%, but the functioning adenoma, we must remove the totally. And that means why we have to remove the tumor in the cavernous sinus. So I show you the sorry, just a moment. Sorry, once finished, I try to how about this? Can you see the monitor?
We can see it.
Yes, yes.
Okay,
clearly.
okay. Oh, okay, it's okay. So this is a non-functioning adenoma, cross grade 4. And in this case, we open the anterior wall of the cavernous sinus. And of course, there is much venous bleeding. And we use this case surge flow. Such a matrix is very useful to control the venous bleeding. So remove the tumor and pack the side cell or xerotin sponge and use the surge flow. We repeatedly remove the tumor piece by piece. And of course, we have to find where is the ICA to prevent ICA injured. So the meticulously control the venous bleeding and remove the tumor. And here is the ICA and remove the tumor. So this case almost totally removed, but only here tumor was left. And this case is a cross 4 GH tumors. And after remove the main bulk of the tumor, I change the endoscope to the 70 degrees. This is the ICA. And using angled suction, remove the tumor meticulously. And now I remove the tumor behind the ICA here. And shield capsule was removed. And such a cross 4 case, venous bleeding is not so much, so it's not difficult. However, this case is a cross 3, tumor in the cavernous sinus, and we have to remove the inner membrane of the cavernous sinus. So it's more difficult than previous case. So I mean, there is much venous bleeding like this. So we remove the tumor inside the cavernous sinus and also remove the inner membrane of the cavernous sinus like this. And I prepared this is a gelatin sponge surrounding the surgical field, and remove the tumor and immediately packed these materials to the cavernous sinus. In this case, also totally removed. Next case is close 0 or 1. It is most difficult case because, like this, behind the inner membrane of the cavernous sinus, there was tumor. So we intentionally opened the cavernous sinus, cut the cavernous sinus and open the cavernous sinus. And of course, there's so much venous bleeding like this, but we have to remove this tumor inside of the cavernous sinus. So this case also totally removed. After such an innovation in instrument and aggressive tumor removal in the cavernous sinus, especially GA tumor grade 3 and 4 improved from 26 to 67% since high definition type endoscope introduced. And the next codomer we have to remove totally. And after the main bulk of the tumor, we check the cavernous sinus. This patient presented the left oculomotor nerve palsy. So here is the tumor invasion. So here is the pituitary gland, and now I remove the behind the ICA and open the cavernous sinus wall. And here we found the tumor and removed the tumor totally, like this. And in this case, cavernous sinus was maybe packed by the tumor using side flow. Venous bleeding control is not so difficult. And after remove the calcified region, tumor was totally removed. But this case, craniopharyngioma, especially intracellular type craniopharyngioma, sometimes invade to the cavernous sinus wall. We experienced the two cases. This is 18 years old woman. And this type of tumor severely adhere to the surrounding structure. So this is the cavernous sinus wall. Remove the tumor, adhere to the cavernous sinus wall. There is so much bleeding like this. It is very difficult to control the venous bleeding like this. So much bleeding. So the remove the tumor attached to the cavernous sinus wall mean remove the inner membrane of the cavernous sinus wall. So I try to remove the tumor of this region 3 times, but each time like this, so much bleeding. So I gave up this case. Tumor was removed subtotally and finished the operation. So how to avoid the complication after removal of the tumor in the cavernous sinus? Blood loss. We need a nearby standby method. It means I prepared something packing material surrounding the surgical field, and I can immediately pack this material to the surgical field. And recently, hemostatic matrix, surge flow and flow cell, it's drastically changed the tumor removal for the cavernous sinus. So we have to use these materials. And cranial palsy, after the surgery, sometimes present cranial palsy. So overpacking and is no good, and surgery is no good because it becomes so solid. So gelatin sponge and hemostatic matrix is better. And tumor actually embedded to the cavernous sinus from the post-oculomotaris. It's so difficult. So at this time, we need a real-time graphic monitoring system. It's very convenient, useful to prevent complications after surgeries. IC injury, I experienced 2 cases. So we need a Doppler and ICG endoscope and navigation. These instruments are necessary to remove the tumor in the cavernous sinus. So conclusion, our surgical innovations in endoscopic manipulation contribute to remove pituitary tumors invading the cavernous sinus. We aim to remove the tumor as extensively as possible while avoiding injury to the internal carotid artery and preventing the cranial nerve palsy and need for blood transfusions. Thank you for attention.
Okay. Thank you, Amano Sensei, for your nice presentation. And Dr. Asmi, if you have any comment or question, please.
Thank you very much. I always enjoy your presentation, Professor Amano. So I have a couple of questions. Number one, for Cushing. Cushing disease, they tend to be aggressive, so they tend to be invaded. Do you routinely remove the cavernous sinus wall in a macro Cushing?
So I think Cushing disease is the most difficult one, and sometimes invade to the bone, not only the cavernous sinus, but we try to. But recently, we often use a medication, brand new medications is so good for the remission.
Okay. My second question, recently we had a difficult case of recurrent anaplastic meningioma, suprasellar and cavernous sinus invasion. So, and patient also underwent radiation therapy, so make the tumor very firm. So we opened the cavernous sinus and it ended up with injury to the ICA. So we managed to tamponade it, but it complicated with thrombosis of the ICA. So do you have any suggestion or any tricks how to minimize a complication for ICA injury when you enter to the cavernous sinus for invasive tumor?
So you mean not only the meningioma, all cases?
Yeah, first for meningioma, post-radiation therapy.
I think a meningioma is different from all other tumors.
Yeah.
Because one case I experienced the tumor invade to the ICA. So just remove the tumor inside of the cellar, but the ICA exploded.
Oh.
So the other tumor, craniopharyngioma, adenoma, never invade to the ICA, but meningioma, possible.
Okay.
So I hesitate to remove the tumor inside cavernous sinus. And I recently, I often use the combined surgery for the meningioma surrounding the pituitary regions. So I don't know how to do that for the meningioma, but the combined surgery is less the complications, I believe.
Do you think the use of ICG and pre-op DSA?
Yeah. Of course, ICG. And even we identified where is the ICA. One case ICA injured. That case is a GH tumor after the repeated operation, and some connective tissue adhere to the ICA. And just I peel off the connective tissue, ICA exploded.
Oh. What about Doppler or ultrasound? Ultrasound for the transsphenoid.
So that if we, of course, everybody use the Doppler and the ICG and navigation, and even we identify the ICA location, but sometimes ICA exploded. So that case we have to take care. Of course, we check where ICA. Yeah, but the chordoma is very difficult to identify the ICA's location, and sometimes even resect the bone surrounding the ICA. I didn't experience, but my friend said remove the bone just surrounding the ICA. ICA exploded. So you must take care, especially in the chordomas.
Yeah. Okay. Thank you very much.
Okay.
Thank you, Asmi. And maybe Yokota Sensei, if you have any comment?
Yes, thank you for your beautiful surgical video. So my question is, if you have injured the ICA, what technique do you use in that situation?
Just packing.
Packing,
Just
yeah.
packing. And
Okay.
after that, I depend on the endovascular team.
Yes,
So
yes.
I experienced only 2 cases ICA injured, and the first case, my suggestion is to call other doctors. So
Yes.
at that time, that operation is only me and the freshman.
Mm-hmm.
So
Okay.
no assistant. So second time, I remind the first case and call the doctors, other doctors. Anybody okay?
Mm-hmm.
Anybody okay?
Okay.
But so many
Okay. Yeah.
neurosurgeons we can do. And, at that time, most important thing is to be relaxed,
Mm-hmm.
not in half.
Mm-hmm.
So other, senior doctors advise me so many things. So call other doctor is most important thing when we injure the ICA.
Okay. So
Okay.
after that, before closure, you use the abdominal muscle
Mhm.
for the ICA wall.
Even I didn't do that.
Oh,
2 cases, all cases the endovascular team treated
I
and
see.
no complications after the surgery. But that's
Mhm.
fortunately, I think so.
Okay. Thank you.
Okay, thank you, Dr. Yokota. And I see on the Q&A panels, you have one question. Do you use intraoperative neuromonitoring when you maneuver into cavernous sinus? Amano Sensei, yeah.
Yeah, monitoring. Yeah. So
Yeah.
I use our boss reported the real-time electrographic monitoring system. It's very useful. Yeah, we need it. And after using this method, this monitoring, after the surgeries, cranial palsy, never we experienced.
Okay, thank you. I have just one question, Amano Sensei. In your experience, how many cases you use for to make a combined approach, endoscopic
Common approach, I
and
didn't
then use
calculate
the open cranial and then
nearly 50 or so.
50%. Okay, okay. So
Percent.
you
Percent, you
planning?
mean percent?
Yeah, percent. Yeah.
I thought
You plan
how
earlier
many
or
cases?
yeah? I mean, you plan that maneuver in a previous surgery. You have operative plan for that, or maybe you decided after the endoscopic procedure you use. Yeah.
Recently, we percentage of to choose the combined surgery is increasing because
Oh, I
not
see.
only for total removal, but in some cases, I remove the tumor via TSS, but open surgery teams open the optic canal. In that case, the patient visual disturbance drastically improved. And some cases, perforator is detached from the open surgery. That's very relief our mind. And even the case, if we remove the tumor only via TSS, but support via open surgery is very, good for the reduction of the complications. So recently, we increased the percent of combined surgery.
Okay. Thank you, Amano Sensei, for your great presentation. And now we move to the third speaker, Professor Xin-Hu Yang from Tianjin, China. He will talk about the supraorbital keyhole approach in clipping anterior circulation rupture aneurysm.
Thank
Please.
you.
Yeah.
Thank you, Asla. Let me share my screen.
Please.
Okay. Can you see that? Okay. This time I'm very honored to participate in this.
Sorry, Professor. Maybe
Okay.
you can use the wider view. I think it's too small here.
Yeah, I see. Okay.
Okay.
And before start my presentation, I want to show a case of ruptured ICA internal carotid artery during endoscopy transnosal approach. Because I'm a vascular surgeon, I was called by the endovascular team. During their surgery, there is a rupture. Because the situation is very seriously, we don't have too many picture and videos. I only took this one pictures, and this is the DSA for the patient, and we put 2 balloons over there and stop the bleeding, and the endovascular surgeon can finish their work and seal the rupture point of the ICA. So endovascular can help with the endoscopy, and that's the I only have one case of such situations. Okay, let me return to my presentation today. Okay, today my presentation is the keyhole approach for clipping ruptured aneurysms. There's nothing to be declared. Aneurysm is a very common disease, and our teachers, the very early generations of neurosurgeons, they start to treat the aneurysm and for the rupture one and the unruptured one. So in recent 50 years, we can have many treatment methods. The traditional treatment is clipping, and with about 30 to 40 years, coiling is a very important another method. And in recent 10 years, flow diverter began to use in the ruptured aneurysm. And to compare with these 3 methods, thoroughly understanding the treatments, I make a comparison between these 3 methods. And for the clipping is the fixed method is stronger, and for the coiling, sometimes there will be a recurrence. And for the open surgery is working under the microscopy, and we can see the aneurysm, and we can make a clipping. And but for a doctor who can clipping a ruptured aneurysm, they need a comparatively long time training, and the coiling may be in a big center for coiling. The training timeline may be much shorter. And for the flow diverter, post the surgery, patient need antiplatelet medication. And for rupture aneurysm, there in the real world, what's the real result? We don't know exactly right now. And so I think coiling and clipping is 2 major methods for the ruptured aneurysm. But many centers, they cannot, there are no real world results to compare these 2 methods for the rupture aneurysm. Only one paper I found is 2018, and they compare. This is a multi-center trial and retrospective statistic for the treatment with these 2 different methods. And the result is a little bit favorite for the clipping. And this is a huge, very big sample, and I think for the rupture aneurysm with a very high mortality and a very high morbidity is quite different from the unruptured one. So I think clipping is also, although the endovascular developed very quickly, and the clipping is still have its position in our modern time. But the small aneurysm is more challenging, and especially for coiling and plus clipping. So if a center received the patient for subarachnoid hemorrhage, and we need to grade the patient with hand height grading and features grading system, and we need neurosurgeons, and we neurosurgeon control the techniques and with very valuable equipment. And we need to know the patient's condition of core existing diseases. So we need neuroprotective medication, and we need ICU to monitor for the patient. So this treatment still with some controversials. And for narrow neck aneurysm is very favorable for coiling, but also favorable for surgical clipping. But aneurysm with unfavorable configuration, such like wide neck, shadow dome, and the branch incorporation, there may be need more complicated techniques like stent or balloon assistance or double microcapsular techniques or flow diverter. And for surgical, there are also some difficulties. Need more case and to accumulate the experience and the time of training. So keyhole approach for most post anterior circulation is the craniotomy in the lateral frontal with 3 centimeter in diameter. If the craniotomy is the same with the suborbital or lateral frontal approach. But the difference is the incision in the scalpel or in the eyeball. So for this approach, keyhole approach, we need before the surgery, we need vascular imaging study and make a detailed for the surgical plan. We need a proximal control and the CSF release. We need to do the surgery with sharp dissection, and maybe we need remodeling clipping techniques. So this is the fundamental techniques for young neurosurgeons to train themselves and under microscopy and with very good instruments and identify important structures. And remember that we are working on the vessels. Never injure them. Do your best. Never injure the vessels and keep the vein and the arteries intact. So the keyhole approach is minimal in the procedure, and we can use it to avoid the iatrogenic injuries, and we can achieve good results. So I can present some cases by video and compare to the coiling techniques. So for the small aneurysm for the coiling, the procedure rupture is the most serious complications, and maybe due to the perforation with the micro guide wire or microcapsular, and during and it may be occur during coiling placement. This is a keyhole approach for the ACAM aneurysms. This illustration, because unruptured aneurysm, we can see very clear and under the microscopy. So with a keyhole granulotomy, we can dissect the arachnoid and gradually we approach to the aneurysm. We can see the aneurysm, and then sometimes we need to remove some piece of rectal gyrus. So this time we can see that there's some very important perforator near the aneurysm, and the aneurysm, there are two aneurysms in the ACAP, not a single one on the CT angiography. So under microscopy, we can see the real world. So one clipping, clip the one aneurysm, and with another one to clip this another small one. So with unruptured aneurysm, we can see the approach. We can see the optic nerve, the A1, and the aneurysm very clearly. Oh, sorry. But with rupture one is totally different. There is maybe there is a hematoma, and under microscopy we cannot see very clearly. This needs training. We understand the anatomy, so we can see the optic nerve and controlate internal carotid artery. With this part, we need temporarily clipping the controlate A1 to get a proximal control. And then we dissect the neck of the ruptured aneurysm. We can see there's some hematomas in the top of the aneurysm. So we can dissect the aneurysm from the surrounding tissues, and we can see the aneurysm, and we can clip it. So from this time, we need to remember that the controlate and isolate the A2 is very important. Never clip the A2 with the aneurysm neck. We need to check the patency of the A2. So new aneurysm, we can say that with clipping is needs training, and also for the coiling, we also need some understanding for the small aneurysm is how we can safely treat for the patient. The techniques we need is to optic shaping the mesocapsular for a point to the aneurysm, and we need idolize the location of the microcapsular around the aneurysm neck, and we need to relax and for the control of the microcapsular to reduce the tension of it, and slowly coil delivery than ordinary aneurysms. And so we can say this is another case we treated with the coiling techniques, because there is too many this Fisher 4 subarachnoid hemorrhage patient grade is so high, we have to coil for the patient, and this is a video for these treating procedures. And after DSA, we found that there is a small aneurysm with a bulb on the top. There's two bulbs of the aneurysm. So we approach the aneurysm with microcapsule and deliver the coils. So we can see, compared to open surgery, it's quite different. This is working under the fluorines. We can see the aneurysm and the coils on the screen. So we need slowly and very carefully deliver the coils, and with roadmap, we can keep the coils inside the aneurysm. So after insert 4 coils, we fill the aneurysms. So we can see from the picture there's we insert 4 coils and achieve a compact coiling for the aneurysm. So because this patient the Hunter-Hess grade is very high, the patient need a long time recovery, and we set ventricular drainage for this patient, so that for some, maybe we think we can collect the aneurysm for this patient, but the patient was in coma when the patient came to the department. So for the consideration for the grading, and we choose the coiling for this patient. And also here is A3, A4 aneurysms for we treated with coiling. Okay, let me play the video. So this is the A3 and A3 aneurysm. This is the unruptured one, and we can approaching the aneurysm very easy with the catheters. When we arrive this A3, we can confirm the aneurysm, and we advance the catheter to A4 to make a protection for the coils. We don't deploy it. We don't use stent. We only with the catheter assistant coiling. Oh yes, we applied a stent. Yes, we applied a stent. So this is the quite difference, 2 different methods, but with different methods, we can achieve treatment results almost the same, but we need a good choice. Which one is better for rupture aneurysm for those patients? So in our department, young neurosurgeons are treating for clipping and coiling all the same time. So this vascular surgeon to be treated this patient. So this PCAM, the ruptured PCAM aneurysm, this also treated by coiling. So PCAM aneurysm is easy to see, but it is not easy to treat for the treatment, especially for clipping. PCAM aneurysm sometimes we regard it is easy to clip, it's easy to see, but it's not easy to clip. To my mind, the rupture of the aneurysm during procedure on theater, the most frequent is the PCAM aneurysm. So this is a very small one, and the patient would like to the aneurysm to be coiled. So we perform coiling for this patient, and although it's a small one. So this is the first coil. We make a bracket to stable in the aneurysm, and we can advance another aneurysm, another coils. So we can see that this is the final result. It's also a ruptured aneurysm. But sometimes we can see with subarachnoid hemorrhage, this small aneurysm, we cannot insert coil into these small ones. These are only 1.5 milliliters in diameter, and the branch of this artery is anterior coronal artery. If this artery occludes, the patient will be hemiplegic. So we perform surgery for this patient. We can say this is the rupture aneurysm with many subarachnoid hemorrhage. So we do the operation for open surgery for this patient. So we can say the very small aneurysm right here. We cannot coil. We think our choice is right. So this is the result. So the patient recovered very well because we preserve the anterior coronal artery for this patient, and we also perform the lateral frontal approach with a keyhole craniotomy. So for the MCA aneurysm, with this approach, also we can do the surgery for patients. But the direction of the surgery is totally different. We can relax the brain when we cut the arachnoid memories, and we slowly move to the hematomas. So we get temporary clipping, and we dissect for the aneurysm, and we say that this is the aneurysm. So we apply a clip to transfer the ruptured aneurysm to unruptured aneurysm, and then identify that both M2 is preserved. And for the safety, we apply another clipper to make it strong. And finally, there is a dog ear. So we put a small clip also for the patient. So for the anterior circulation, keyhole approach is okay. But for the post circulation, sometimes we cannot perform keyhole approach, like the pica ruptured aneurysm. Even the aneurysm is in the very low position, we have to open cannot perform keyhole approach, and we can do the operations. But for the endovascular, it's sometimes even the small one, we can working with catheter-assisted coiling, because the vascular is prefer for the catheter to approach to the working place. And on the top of the basilar artery, we can have the surgery and the endovascular two methods, and we can do select for the patient for the right choice. So we can perform with stent-assisted coiling. We can put the coils very content, so we can seal the aneurysm. And even with the two left of the aneurysm, we can coil it, and with a very satisfied result. But sometimes we still need open surgery, need approaching to the aneurysm, like traditional approaches and the endovascular approaches. We can, but this picture I copied from the papers, and our method is to do the surgery by subtemporal approach, and because subtemporal approach have short working distance and can avoid post clinical processes, and we can view the aneurysm neck better, and we can view the perforators and easy to apply temporary clippers. So this ordinary surgery, the first we need to open the craniotomy as low as possible for the middle cranial fossa, and we need to release the relax the brain to release the CSF first, and we need to identify cranial nerves in the procedure, because the ruptured aneurysm, there's a lot of blood in the systems. We cannot identify the structures very easy. So we need orientation. So this is an example for the ruptured BA top aneurysms. There's subarachnoid hemorrhage on the CT scan. After the CT angiography, we found a very, very small one. This is the most small aneurysm of BA in my experience. So we perform the DSA. The aneurysm is very small. So we perform a temporal approach. So we can see the cochlea and the oculomotor nerves, and we identify the BA A1, and when we try to apply a clip, the aneurysm ruptured in the procedure, and fortunately, we can put temporary clippers around the ruptured aneurysms. Okay, this is a picture post surgery. The patient have oculomotor paralyzed, and she recovered several months. And the nerve we need to identify the trochlea, and from this final view we can say that with the green tea is the tantrum we opened, and with slit we open it, so we can go to the system before the middle brain, and another green tea is trochlea nerve, and green O is the oculomotor nerve, and the red P is the post-clinoid, and the pink M is the middle brain. So from this approach, also we don't open the craniotomy very, very big, with the size of around 3 centimeters. We can approaching to the basilar top and clip the very small aneurysm. So in summary, I think the best technique is the choice for the patient, which one, either the open surgery and either the interventional techniques, is which one is better, is the best surgery. That's my report. Thank you very much.
Okay, thank you, Professor Yang, for your great presentation. So you apply the minimally invasive philosophy to treating aneurysm, both with endovascular and also with keyhole surgery. So please, Dr. Asmi, you have any comment or question, please?
Thank you very much, Professor Yang. I really enjoy your presentation. You have described well-versed range of option applying the keyhole concept as well as the endovascular. So my question is on the high frontal incision compared to supraorbital. So how do you makes the brain relax? Because if you come from above, so you really have to get down base, so you really need the frontal lobe to be released. So is it you release your seal and fissure first, and how do you control when you have ruptured? How do you get a proximal control?
Okay, Thank you for the very nice, very good question. Is the key point, and with very small craniotomy, especially post rupture, for these subacute hemorrhage patients, the brain sometimes is look like edema. So when we open the dural, sometimes the brain is swollen. The very narrow spaces give us. So my method is to go through to the optic nerve with the along the skull base from the. So we need to remove the bone of the little of the on the top of the along the the bone of the orbital roof to the optic nerve. Slowly we can we can isolate the hemorrhage the CSF. So with maybe 5 to 10 minutes, we can absorb the CSF and relax the brain. And with those, and at the same time, we need dissect the ironic memories with very sharp scissors and relax the after we cut the memories, the brain is also relaxed. And this is the first method, my method to relax the brain and give the space to approach to the aneurysm. And the next question is, what can we do if it's ruptured? So my method is put the aneurysm in the last step, and dissect for the proximal arteries first, and then the distal arteries. Let the aneurysm covered by the brain or some other tissues, and don't open the aneurysm first. Keep in my mind, I surgery the aneurysm to be the last one to explore. And when we can apply temporary clippers, then we move to the neck of the aneurysm. Don't surgery on the top of the neurons of the aneurysm where the rupture point may be on the top. That's my method. It's not very good.
Thank you. Very well explained. My second question, we know that the endovascular therapy become one of the popular, but studies have shown that open technique clipping has better obliteration and rate, as well as reduce the rate of recurrence for anterior circulation aneurysm. So in your current practice, how do you decide which one for endovascular, which one for open keyhole clipping?
I think my idea came from when I was studying in Japan, about the 20 years before. There's cameras in Tokyo, in Akihabara. In the Sunday, we go to there, see many cameras. Some cameras are very easy. That's just put and take a picture, and some are very difficult. You need some parameters adjust to get a very good picture. So to my mind, the patient's requirement is the good result. He don't care what's your job and what's the doctor, how difficult the doctor will face. So my mind is that which method is easy, which one is the better. If the endovascular is easy, we perform it endovascular for the patient. We need consideration for the safety and recurrence for those patients, and sometimes maybe stent, maybe flow diverter. We need to consider for patients for the antipyretic medications. So that's the balance which one is not only on the table, but also in the follow-up. Combine together which method is easy. I prefer the easy one. So
Okay, thank you very
much.
Thank you.
Thank you, trust me. Yokota Sensei, you have any comment?
Hi.
Yes, thank you for hi. Nice to meet you. Thank you
Nice
for
to
your
meet you.
thank you for your wonderful presentation. My question is the same as Professor Azmi. So I think when you have intraoperative rupture case with the keyhole surgery, can the assistant doctor insert the suction?
Okay.
I think a small space.
Yeah.
How to do?
This is sometimes this will be symbolized for the endoscopy surgery, because endoscopy also approaching the diseases with a very small opening, craniotomy or nostril. So for my operation, I prefer do it by myself. Unless it's ruptured. If there is a rupture, we need two suctures. I need my assistant suctor for the huge bleeding. I can working with another one and found the neck and put a clipper. So I prefer one doctor with two hands, and so this sometimes I need some suture and bipolar, and so I change bipolar with scissors and with right hand, but the suture always is my left hand. Okay.
Okay, thank you. And another question I have, one more question. Don't you use the endoscope with the keyhole surgery?
Yes,
Sometimes.
I hope I can, but I don't have the chance because endoscopy technique came to my hospital about the 10 years. We have a special team for endovascular, and if we need endovascular techniques, I will call the endovascular doctors came to assist me to help me. And you can see the first I show the case. That's the endoscopy doctors call me to put balloon for the ruptured ICA. Okay.
Thank you.
Thank you.
Thank you, Yokota Sensei. And Dr. Ben, you have any comment?
Yes, and
Hi,
congratulations. Hello, Professor Yang. Nice to meet you.
Nice to meet you.
Congratulations on your work. And then long time no see as well. And I would like to ask about for the supraorbital approach and for ACOM aneurysms, anterior communicating artery aneurysm.
Yeah.
So which side? How do you decide which side would you approach the aneurysm?
Yeah, that's a very important decision before the surgery, and
Yes.
I prefer to approach. I would like to select the size when I came into the very deep position of the ACOM. I can see the neck directly without cover of A2. Sometimes because I can divide the aneurysm for two directions. One is to the down direction, down direction. The aneurysm may be stick to the optical chiasm or stick to the skull base. Another direction is to the upside. So to the when the direction to the upside, the aneurysm will cover by the brain. So in this situation, I would like go to the aneurysm neck with direct seeing the aneurysm neck without any obstacle, like A2. Sometimes we go with went down to the aneurysm with the A1 is predominant, but sometimes the A2 is covered the aneurysm neck. So at this situation, we need put clippers with some complicated. So I prefer go to another size. And if the aneurysm dome is pointed down, I think go with the predominant A1 is the best. Okay, sorry. Maybe with some
Yes, I
picture
understand.
we can discuss the more in detail.
Yes, I understand, and I think this is very important, especially given the narrow corridor with the you have to make the correct size to facilitate surgery. But again, congratulations, and hope to see you soon. Thank you so much, Professor Yang.
Okay, thank you.
Thank you, Dr. Brang. And I think this is the last question from the Q&A panel from the audience. Dr. Pavlo Bizilia, do you routinely perform DSA before surgery, or is it just with CT angiography for preoperative planning?
For surgery planning, for clipping for the rupture aneurysm, I prefer CT angiography, because the CT angiography we can have the skull base and identify which approach, and we can practice with the CT angiography, and we can edit the approach. Like we remove some the bone, and we can see the angle we get tricked down. But when we try to perform coiling for endovascular surgery techniques, we must have angiography first, and we can understand the vessel architectures. We can know which artery we can put a stent, and we can advance microcatheter across the neck of the aneurysm. So for different methods, maybe the planning angiography or CT angiography is the difference.
Okay. Thank you, Professor Yang. I think we finished about the presentation, and congratulations for the three distinguished speakers today for the great presentation. So please, Dr. Asmi, you can conclude or something, please. Yeah.
Thank you very much on behalf of ISMIN and of course the organizing committee, especially from ACNS team, especially Rajakuti and all the invited speakers to have this joint session emphasizing on the minimally invasive technique in neurosurgery, ranging from the endoscope, and then we have a keyhole approach, and of course the cavernous sinus tumor by three excellent speakers. So I would like to thank everyone who participate in this, and of course from your Professor Yoko Kato for providing this excellent platform, especially for young neurosurgeon, because a lot of new things coming out in our current practice, and there are many options. By listening to the expert who has more than maybe 20, 30 years experience, and just sharing 10 minutes discussion is really beneficial, especially to share the tip and tricks to have a very good outcome. I think I would like to thank also Dr. Asra for chairing this session, and the rest, and of course Yokota for co-moderating this session. So thank you very much from myself. So maybe last from Professor Yoko Kato.
Yeah, so thank you so much. Especially my work in clipping surgery, somebody with hemorrhage. Thank you very much, Dr. Yang. Recently, there's and there's invasive treatment for both the surgeon and the patient. So getting the less use of the coiling Because coil sometimes rupture of the aneurysm or sometimes intraoperative rupture. So, and also the web. Now we can use smaller size of the web. So the aneurysm is less than 5 millimeters. I think especially the acorn aneurysm is quite a complicated anatomy, and also if the rupture case is very swelling of the brain itself, I think. So should be treated by endovascular is much easier, faster, and good for the patient, I think. So, but we have a very nice the 3 talks today. It's a good fit for the ISMINS webinar. So thank you so much, as me and also as and also Mao Sensei. Thank you so much. Shall we finish?
Yes.
Asa Sensei?
Yeah.
Yes.
Can we take a group photo?
Yeah.
Yes, of course.
Who gonna take it?
Raja maybe. Or
Raja,
Ben.
Raja. Where are you, Raja? I think he's traveling.
Liu, maybe Liu.
Or maybe I screenshot from here. Or Ben,
Oh,
Ben, can you take Ben?
No, it's on my phone, and I think maybe ask me, you take it because I'm
Yeah.
using on my phone.
All right, everyone smile.
Okay.
Okay, one more.
See you next time.
Okay, see you everyone.
Happy
Bye.
Ladies' Day, Kato Sensei and
Hi,
Yokota.
hi. Thank you
Thank
very
you.
much.
Bye-bye. Yeah.
Okay.
Thank you, everyone.
Bye-bye.
Bye-bye.
Bye-bye. Thank you.
Bye.
See you.
Albert and Ben. Bye-bye.
Bye-bye, Professor.
Okay.
Okay.
Nice to meet you.
Okay.
Bye-bye.
See you next time, Amano
Yeah.
Sensei. See you next
See
time.
you next
Yes,
time.
Amano Sensei.
Okay.
Amano Sensei,
Thank
all the
you.
best.
Alberto,
Yeah.
see you next time.
See you, Professor Yang.